invite our next speaker, Dr. Shri Ganesh. He is a prominent figure in ophthalmology, chairman and managing director at Netradama Hospitals Private Limited, an exceptional surgeon, as I'm sure you will now notice. On to you, Ganesh.
Hello. Thank you, Dr. Keki, and for inviting me to this IC. And I'll present some of the newer techniques of scleral fixation, which is the modified 4-flange technique. So optical rehabilitation in patients with aphakia presents a very unique challenge, and choice of the IOL implantation in the presence of little or no capsular support includes an antechamber lens, an iris fixated IOL, and a scleral fixated IOL. Each of these techniques has its own merits and demerits, so let's look at them. The AC IOL can cause potential damage to the corneal endothelium and angle structures, and by and large has kind of become obsolete. The iris fixated IOL, like retrofixation of the claw lenses, are quite popular. It's easy to do, but you can have pigment release and inflammation. The scleral fixated IOL has the advantage of a more physiological position near the nodal point of the eye and the greatest distance from the cornea, so it is more friendly to the endothelium. So sutured scleral fixated IOLs have been the traditional way of fixating IOLs, but there can be quite a few complications, including suture erosion, breakage, what is known as the yo-yo syndrome, lens dislocation, etc. Quite a few complications, and this is mainly done by the retina surgeons, posterior segment surgeons. Professor Amar Agarwal introduced the glued IOL technique, and it has become quite popular, where you make scleral flaps, but again you need some amount of surgical expertise and then the handshake technique. You can have some complications like scleral flap issues or haptic extrusion or haptic breakage. Then you have the M&A technique. Again, this is a popular technique but has its own challenges, like it is technically challenging to do. You can have a higher incidence of IOL decentration, tilt, pupil capture of the IOL can be a problem, and vitreous hemorrhage. Canabrava described the 4-flange technique. Again, it's becoming popular because of its simplicity. You need calipers, 27 gauge needles, 6/0 polypropylene sutures. The IOL is a PMMA IOL with eyelets and a thermal cautery. And in this technique, basically what he does is he introduces a 26 gauge needle and railroads the proline inside the eye and then pulls it out. That is done on either side, diametrically opposite each other. And in what we did was we modified the 4-flange technique. So you cut out 2 pieces of 6/0 proline, approximately 5 centimeters, pre-thread it into a 27 gauge needle, so that even if there is any corneal opacity or so you can still do it. It's almost, you don't have to visualize. You're not doing many things inside the eye. Just gently push the proline so it extrudes through the needle, and then you can just pull it out through a microforceps. And this makes it much easier, and you don't have to have so much of dexterity to railroad the proline. Once you pull it out, you just put it through the eyelets of the PMMA and use a thermal cautery to create the flange. Put the IOL in, pull on the proline sutures so that it's tight, and then cauterize and flange the external proline, and then you have a nice secondary IOL. These are some of the challenging cases. This was a case of trauma, aniridia, where retinal detachment surgery and corneal grafting, a tectonic graft was done, and it was aphakic. A bad road traffic accident. Here we planned an aniridia IOL. So there's the same technique where we preload the proline, pull it out. I've released some of the sutures, and this is a very large lens. So you put in the proline through the eyelet, you have to see that the flange is on the posterior aspect. The direction is very important. Similar kind of flange is done on the other side, and then the lens is actually put in. Here, of course, there is no vitreous because vitrectomy has been done, but some of the peripheral, little bit of peripheral strands we kind of, and then remove the sutures, because again here we have to do a regraft, because this was just a therapeutic graft, has to be exchanged for an optical graft. So put in the lens and then pull on the sutures so that the IOL centers well, hold it, cut and then cauterize. So it's actually quite simple to do, and even my fellows are able to pick up this technique. Just pull the conjunctiva, so you don't have to reflect the conjunctiva, and then this graft was kind of exchanged for an optical graft. And then the new graft was placed, and that is the end of the procedure. So I will show you the post-op pictures. This was how it was looking day one. So this is fixation of the aniridia lens combined with a corneal graft. And this patient did quite well. Another interesting case was a Marfan syndrome. Now this patient was a 14-year-old with severe subluxated lens and had also corneal astigmatism of about 2.5 diopters. So ideally a toric lens should be used. Now I have developed what is known as a swivel haptic IOL. So we decided to use the foldable swivel haptic IOL because you can't open the incision and you don't get torics in PMMA. So let me show you the technique. So here that is the Callisto. I just put in a trocar cannula for infusion. Then I go in and then I just do a lensectomy. I just aspirate the soft lens material. So I do a capsulorhexis. I don't like fixating the bag because this is progressive. It's a progressive condition where you can have progressive subluxation. I just use the IA to remove the lens matter, then just remove the entire capsular bag with the microforceps, and now you have aphakia. You can do a vitrectomy, antravitrectomy, and this is the swivel haptic IOL. The swivels have holes in the edges, so you can actually load the lens into any cartridge. You put it in front of the iris, and then you're using the 4-flange technique to fixate the swivel. So that is how the 6-oprolene is passed through the eyelet of the swivel haptic and cauterized. This is a toric lens, so you can see that you have to be exactly 90 degrees from the axis and do the entry with the needle. That's the flanging being done on the other side. And when you actually pull on the lens, pull on the proline sutures, you can see that it is on axis. The external cauterization is done for the flanging and the conjunctiva is closed. This is the end of the procedure. You can see that the lens is fairly on axis, and this patient did quite well with an uncorrected vision of 6/9. So these are a few of the interesting cases. In our experience, we just looked at a retrospective case series of 52 eyes, mean age of 65 years. We had a follow-up of 1.5 years, and these were the indications which included introp PCR, introp ZE, trauma, Marfan syndrome, subluxated IOL, dislocated IOL, where we used the 4-flange technique. And these were the visual and refractive outcomes, which was fairly good. You can see that the corrected distance visual acuity was around on average 0.25 logmar. The residual sphere was 0.28, so fairly good refractive result. Of course, PMMA lenses being used, we had some amount of astigmatism. And the IOP was normal over the follow-up period. These are a few of the clinical pictures, day 1, 6 months. And we also did the UBM, and you can see that the lens placement is very nice with no tilt or decentration. We had actually few intraop complications, one haptic slippage, one intraop IOL tilt, one haptic breakage. Otherwise, 49 of the eyes were all normal. Again, you can avoid these. This was in the early cases. So you shouldn't leave the suture loose. You have to actually pull it and then cauterize it so it's flush against the sclera. So there is no movement. We had flange exposure in one case because of a loose suture. We again revised that and it was normal. IOL tilt in 2 cases and hypotony. And this is the kind of revision. So you always have to see that you flange it properly and cover it with conjunctiva. And when you flange it, don't touch the proline. Otherwise, it becomes rough and there's a higher risk of erosion. It has to be smooth on the surface. So the 4-flange technique of SFIL is safe and effective, relatively easy to perform, useful in hazy corneas, short learning curve. Thank you very much. And I invite you all for the 37th APSARS in August in Ahmedabad.
Thank you, Sri. As everyone knows about Sri being such an